Thank you all very much for coming. It is my pleasure to welcome you to our webinar series, What to Expect, A Guide to Prostate Cancer. This webinar series is a collaborative project between ourselves and the pharmaceutical company Ipsen. My name is Dr. Sarah Nelson, and I am the Health Information Executive at Prostate Cancer Research. David will be back next week, but in the meantime, I am stepping in to chair today's session, the fourth of our webinars this week on the topic of treatment options, active surveillance, focal therapy, and hormone therapy. Before we get started, I just want to run through a few housekeeping rules for today's session. A Zoom webinar is a little different to the Zoom meetings that many of us are familiar with. So all attendees automatically have their video and microphones muted, and this is so that we can record the webinar. We will then make the recording available to everyone approximately 1 week after the session on our website, and more details will follow by email. So you can see here that we were to be joined today by two wonderful speakers, but unfortunately, Professor Caroline Moore is no longer able to join us. However, we would like to welcome Professor Rakesh Heer, who has very kindly agreed to take the whole session this evening. I will let him introduce himself in a little bit more detail later on, but a big thank you to him for joining us today. This webinar today is the fourth of an 8-part series. So today we'll discuss the monitoring and treatment options available for early stage and high risk localized prostate cancer, including active surveillance, focal therapy, and hormone therapy. Next week in webinar 5, we will be talking about radiotherapy and surgery, side effects associated with each treatment, and the long-term outlook of both therapies. In webinars 6 and 7, we will discuss metastatic prostate cancer and how it is treated, whilst our final episode, webinar 8, is focused on end-of-life care, what to expect, and how to plan for it. So for more information, please do visit our website, www.pcr.org.uk/what-to-expect, where you can find out more about all of the remaining episodes, including who will be speaking in each session, as well as how to watch previous webinars on demand. So for the purposes of today's presentation and for simplicity, we have used the term men throughout, but this should be considered to include not only men, but also trans women, non-binary people who are assigned male at birth, and some intersex people, as they are also affected by prostate cancer. Okay, so it's my pleasure to now hand over to our speaker, Professor Rakesh Heer. So I'm going to ask him now to turn his video on and unmute himself.
Sarah, thank you very much for this introduction. You've heard that I'm a urologist. I'm based in Newcastle, and I look after men with prostate cancer, the diagnosis, and also surgical management. I'm also involved with a number of research projects looking at diagnosis, surgical approaches to management, and follow-up following treatment. So today we're going to go through the 3 major domains that Sarah's already defined. We're going to look at monitoring, focal therapy, and hormone treatment. And we're kicking off here now with monitoring for localized prostate cancer. What we'll cover in this first third is these questions. What does localized prostate cancer mean? And we'll talk about the difference between active surveillance and watchful waiting. Sarah, can I have the next slide, please? So the prostate gland, I suspect most of you know, is a gland that sits at the base of the bladder, as illustrated in that schema there on the right. And the urethra passes through it. It causes a lot of men bother as they get older because the gland grows and it tends to squeeze on the urethra, causing urinary symptoms. The other major phenomena associated with the prostate gland and aging is the incidence of prostate cancer increases. And when we get a growth in that prostate, it's localized, it's confined to the prostate. If it grows through the prostate wall and then it becomes advanced, we call that locally advanced. And then if it were to spread elsewhere, we refer to that as metastatic prostate cancer. So in summary, what we're talking about here is cancer that is confined to the prostate gland. And it's synonymous with other terms: early cancer, stage 1 cancer, or organ confined cancer. This is the earliest stage of prostate cancer. Prostate cancers grow slowly, and at this point, there's a low risk of spreading if detected early. Sarah, next slide, please. Now, depending on the stage, we have different treatments. So if you have a cancer that is metastatic, spread around the body, we have a different approach. We look to treat we take an approach for treatment which looks at treating the entire burden of prostate cancer. An example of that would be hormone treatment. Although hormones, as we'll learn at the end of this talk, can also be used for localized prostate cancer management as well. The different stages of prostate cancer, we will undertake different approaches which primarily relate to how prostate cancer can be cured if it's localized. And if it's not localized, we're talking about incurable disease. When you have localized disease, we have a number of options. Primarily, if the cancer is localized, it's slowly growing, and it's very, very unlikely to affect your life expectancy or quality of life. If you have localized disease, I think broadly speaking, we'd want to characterize those that have tigers. These are aggressive cancers that could grow rapidly and cause harm, and those that are pussycats, which are those that are slow growing and relatively indolent. If you have indolent localized disease, then it is safe to sit and watch. If you have aggressive disease, those tigers, then there's an onus on seeking treatment. Your urologist or diagnosing doctor would advise you on the best approach in that setting. Given that we can often see indolent disease, or even what we would refer to as intermediate or medium risk disease, the growth of the prostate cancer being slow affords us opportunities to take a conservative approach, avoiding treatment. And by avoiding treatment, we can avoid side effects. Broadly speaking, there's two main ways in which we monitor localized prostate cancer without immediate treatment. And those are referred to as active surveillance and watchful waiting. I'm going to go on now to talk about the difference between the two approaches. Sarah, next slide, please. So with monitoring, we're talking about regular checkups. So you've got a cancer, we know it's there, and there's a potential for it to grow, although that is a slowly growing cancer. What we want to do is pick up those cancers that are showing some concerning changes in their growth, those that are at risk of spreading. And if we have the intention to treat those cancers, so this is typically for younger men, where there's more life expectancy ahead, and therefore a greater chance that the cancers can change in their characteristic over time, we use active surveillance. This is where we would intervene if we see a change in the growth pattern, the nature of the prostate cancer. Watchful waiting has a slightly different perspective. And what we do for watchful waiting is we don't have the same intensity of monitoring, but here we're expecting that the prostate cancer may grow, but we're waiting until we need to treat because there may be effects such as side effects from that growth. Broadly speaking, they're both about monitoring. One's about intervening with a treatment to cure, which is active surveillance, and the other is to intervene with the treatment to manage the symptoms, the side effects of that growth. Sarah, do you want to move on to the next slide, please? So on a monitoring program, if you're younger, you're fit, and you're a candidate then to have treatment, which could be surgery or radiotherapy, or as you're also going to hear focal therapy, then you may go on to active surveillance. You may choose that. It's a discussion with your treating clinician. If you've got advancing disease, high risk disease, but you've got maybe risk factors for relating to poor health, meaning that curative treatment is not desired because you've got illnesses with the heart or lungs, then we take a watchful waiting approach. This is also relevant in those that are much older, because it's unlikely the cancer is going to catch up with them in that window of remaining life. So with active surveillance, it's much more intense monitoring, so regular hospital checkups, and there may be scans, there may be additional biopsies. With watchful waiting, we talk about tests and checkups, primarily based around PSA, conversation around symptoms, and that can be done quite regularly at the GP and avoiding hospital follow-up. Now, what happens if you find something with active surveillance? The idea here is to have that intensity of follow-up to pick up the earliest signs, the earliest indication that cancer has changed in its characteristic, and therefore we can intervene with a treatment to cure those individuals of prostate cancer. With watchful waiting, it's about managing the signs and symptoms. So if you have symptoms that suggest that cancer is spreading, or maybe symptoms relating to urinary symptoms, then we can look to treat those with either medical treatment for urinary symptoms or hormone treatments related to prostate cancer spread. Sarah, next, please. So under active surveillance, we've got quite an intense regime for follow-up. We don't want to miss a man who's on active surveillance, moving on to have more sinister features, and certainly not go on to have metastatic disease. In year one, there's blood tests, it's PSA blood tests, and that's done every 3 to 4 months. There's an examination of the prostate with a finger in the back passage. It's called a digital rectal examination, and that's done at 12 months as a repeat assessment. The other thing that we do is we repeat the MRI. The MRI is done at approximately 12 months, sometimes as late as 18 months. In year 2, we keep the monitoring in place with PSA. It's not done as intensely, because if we've seen relatively slow changes in the PSA kinetics, we can be reassured that this is, broadly speaking, a slowly growing tumor, and we can drop the frequency of observation down to 6 months. If you had more rapid growth, then you won't reach year 2. We'll be recommending potential treatment. We'll also repeat rectal examinations, although that's recommended. I think in many centres, you might not have that, and you might have the PSA alone, and you might have the scan with that. The scan may involve a further biopsy if we see any change in characteristics, to see if we can see any tissue-based changes that might suggest a more aggressive change in the cancer. These follow-up regimes aren't well defined across the country. In fact, NICE guidance were unable to give a clear recommendation on exactly how often to do these tests and who should deliver them, where they should be delivered. It's a focus of potential research work to work out what the best approaches may be. And in some centres, you may be looking to have a lot of these investigations and tests in the community, provided by your GP, and only being referred back if there was a problem. In some places, we have a self-monitoring mechanism where patients get the blood tests and the results are fed back to them. And they then can speak to a nurse specialist for support at the treating site, or with previous education, know when it is they need to respond and seek further help, and they go see their GP and seek a referral back into hospital. Or in many centres, the follow-up is still maintained by the treating clinicians, and patients are seen back in their hospital. So there's a number of approaches here, and it may vary to some degree, depending on your local setup. Sarah, next slide, please. So we've already touched on this, that we'll be looking at regular checkups with PSA blood tests, and you may get an examination of the prostate gland with a finger in the back passage. These tests are also relevant for watchful waiting, but in watchful waiting, we tend not to use MRI scans or consider rebiopsy. So it's a much lighter version of that follow-up. It may not also be as intense, so we may only be checking your blood tests on a 6 to 12 monthly basis. Sarah, next slide, please. So what are the advantages of active surveillance? It allows you to avoid some of the side effects associated with treatments. These can be quite morbid, including incontinence, erectile dysfunction. The other advantage is that it doesn't affect your everyday life, like having treatment and living with side effects. And broadly speaking, it's safe. We know that if your cancer were to grow, we're likely to pick that up in a timely fashion, and we're likely to start treatments with the aim to cure your cancer and give you a fantastic outcome. So it's broadly speaking safe, and it avoids side effects. The disadvantages are that in some places they will look to rebiopsy, and that's something that can be associated with complications, infection, pain, blood in the urine. There is a very small risk that cancer may grow quicker than expected. It's unlikely that it grows so quickly that you move from a curable to an incurable state, but it's a theoretical risk. As we get older, there could be other medical problems, and although you might have been a candidate for cure at one point, if you have, for example, a heart attack or a stroke, it changes your health state, and if your prostate cancer was also to progress, you might not be a candidate for some of those major treatments. The last point here is that some people find it very difficult living with untreated cancer, and that can affect your mental well-being. And that's often a driver for individuals switching from active surveillance into active treatments. Next slide, please. So watchful waiting, very similar to what we had with active surveillance. There's no treatment side effects because we're not looking to treat straight away. There's no regular MRIs or biopsies. So this is the main difference between active surveillance and watchful waiting. We're not hunting as hard, and we're not looking to try to identify those localized disease with scans. And if you do get symptoms, we know that there's plenty of treatments we can use to help manage those. So we've already touched on medication for urinary tract symptoms. If there's pain-related symptoms, we can talk about painkillers. If there's spread, we can then talk about hormone treatment to try to contain that, put the brakes on. The disadvantage is very much like active surveillance. The cancer may change and grow. There's anxiety living with a cancer that's growing and getting symptoms. And when you're speaking to your family about having a prostate cancer and it's not having a treatment approach where we're looking to cure you, it may be challenging to explain that to your immediate family and social circle. So very similar to active surveillance. Sarah, next slide, please. Looking at monitoring a localized prostate cancer, we know that the vast majority of men are diagnosed with the early stage, and with monitoring, you can go to active surveillance if you're fit for active treatment, and we'll be looking at you more thoroughly than we would with watchful waiting, where we're saying you're not the best candidate for active treatment, but we will be looking to manage your symptoms. It's challenging to come to terms with watching and waiting, and for some men, it's just not a plausible option. However, if they were to choose active surveillance, we know that 98% of those individuals will be alive at 10 years. So you're safe, you'll have a lot of monitoring, you'll be involved with making an informed decision and choice with your clinician. And if the cancer condition changes, then you can change your mind and you can look for active treatment with localized prostate cancer. Sarah, next. Okay, so I think that's nearly half the talk covered. The remaining half will talk about two topics: focal therapy, and we'll talk about hormones at the end. Focal therapy, we're going to talk about what it is and who it's suitable for. Next, please. So focal therapies are basically targeted approaches. It focuses on the cancer within the prostate gland. Within the gland, it's only a part of it that is affected by the cancer. So the argument would be, why remove or treat the whole gland with radiotherapy? The focal therapy targets just the cancer, and there's some gains with that. Now, it's a new therapy. Not many centers offer this routinely, and we'll touch on the way that we look to monitor this new treatment in subsequent slides. But for some patients, focal therapies offer an alternative to surgery and radiotherapy. And the big gain here is that you can avoid side effects from surgery and radiotherapy. Next, please. So here's an example of a focus of prostate cancer. We've got one in the red, and we've got an illustration of two foci of prostate cancer on the left with the red and the yellow. What we'd look to do is treat only part of the glands that contain the cancer. And this could be done as a hockey stick treatment, so treating that left-hand side and the bottom half of their gland. Or it could be a hemiablation, as shown centrally, if there's just a major lesion on one side. And increasingly, what we can have is targeted treatment of just the tumor and its immediate vicinity. So that's targeted focal ablation. Sarah, next, please. The main benefit of focal therapy is preservation of function and avoiding side effects, but that's traded off with cancer control, where we've got an established approach with radiotherapy and surgery. We know that focal therapy might not be as effective, and we'll talk a little bit more about that shortly. Sarah, next, please. So here's a little example of what a lot of surgeons and patients feel about radical surgery and radiotherapy, in that they're taking a sledgehammer to crack a nutshell. And maybe what we need is less morbid treatment to give us an effective outcome. Next, please. So here's an overview. The advantage is you avoid some of the complications of radiotherapy and surgery, which include incontinence. The rates of incontinence with focal therapy are small. We also see a large number of men maintaining erections, not requiring further treatment, which is relatively common with surgery and radiotherapy. The treatment is delivered as day surgery, and the catheter window is smaller, up to 3 days. The trade-off here, though, is that the focal therapy may not lead to complete treatment of the tumor, and we know that 1 in 5 individuals with their monitoring thereafter require additional treatment, focal treatment, in 5 years. We know that 1 in 5, 1 in 15, so a proportion of individuals then need to go on to have more conventional, what we call radical treatment. That's with the normal radiotherapy, the traditional surgical approaches, and abandon the focal approach. But the rates of conversion that you can see are 1 in 15 at 5 years, and that's acceptable to some men. However, one of the things that is required is some intense monitoring following these treatments. So there is a commitment to monitoring with PSA and MRI and additional biopsies, as we discussed before, with active surveillance. If you look to have treatment thereafter, and if you choose that treatment to be surgery to remove the prostate, having had focal therapy might make that treatment more challenging. Next slide, please, Sarah. So we use a number of ways to destroy these cancer cells, these areas of cancer growth. We can use temperature, electricity, and light activating medication. And we'll just talk through each of those in turn. Next, please. So there's multiple energy sources available, but HIFU uses high energy ultrasound waves. So it involves using a needle, a bit like a biopsy, to push into the prostate. And what we'll do with that is turn on the high frequency ultrasound scans, and that generates heat rising to 60 degrees, and then that ends up destroying the prostate cancer and only that area that the needle is treating. Next, please, sir. Some places use extreme cold. They freeze it in a process called cryotherapy. Again, as we've heard, very similarly, we push a needle through into the prostate gland. We do that under ultrasound guidance, a bit like having a biopsy. And then what we would do is use a probe to cool that part of the prostate. So it very rapidly cool to a temperature of -40. And that triggers a type of hypothermia, kills the cancer cells. And then slowly warming that area up and then giving it a second blast of cold makes the treatment more effective. Sarah, next, please. A relatively newer technology in this space is irreversible electroporation. It's more popularly known as nano knife. And what's being used here is tiny pulses of electricity. What this does is it causes the cell membranes around, so basically the walls around the cells, to become perforated. Tiny holes occur, which causes cell death. And it's a way to give quite controlled energy to these prostate cancer lesions. Very few places offer that. At the moment, there's a couple of centers, UCLH and King Edward Second Hospital. But its use is increasing. As you can see there, it's being used in pancreatic cancer, and there are a number of centers that have that technology and will have the opportunity to extend that to prostate treatment as well. Next, please. So which individuals is focal therapy suitable for? Because it's still a developing space, focal therapy is usually only available as part of clinical trials or specialist centers. They tend to pick out those cases that are at medium risk. Those at high risk, there's still a belief that we should stick to the more conventional approaches with radiation or surgery to remove the gland. But if those with medium risk, where they could possibly undergo a bit of monitoring, or they have features that take them away from a desire to monitor and a desire to treat, but not high risk, would be the cases we would consider. Sarah, next slide, please. So the advantages, if you heard, is it's less invasive, less side effects, less urine leakage, less direction problems. You recover quickly, and you can have further retreatment if your cancer were to return. The disadvantages are that there's a limited number of centers. Most will offer that within a trial context. And you need monitoring thereafter because cancers can recur and further treatment may be required. surgery, if you were to choose that as the radical treatment thereafter, could be more technically challenging and associated with higher risk of complications if you've had focal therapy the first time around. Sarah, next, please. Okay, clinical trials. This is all about answering that question. So if we've got concerns around a treatment, it's a new treatment, we don't know how good it is, if it's safe, what the side effects are. This is what trials are all about. And if you're interested in trials, you can ask your GP, you can ask your treating clinician, a urologist, oncologist, or a nurse specialist, and they will let you know what's available locally. Or if there's interest in trials that's not available locally, you can certainly ask for a referral to one of those centres. Sarah, next, please. Okay, so we're coming to the end of the seminar today. We're going to spend the last 5 minutes talking about hormone therapy, and we're going to talk about what it is and who it's suitable for. Next, please. So one of the things about prostate cancer is that it's very much dependent on testosterone for growth, which is the male sex hormone. It defines the secondary male sexual characteristics and also growth within the prostate during puberty. The prostate gland is something that, if you didn't have testosterone, wouldn't grow to the same extent. And prostate cancers, we know, can be treated by removing testosterone from the system. Historically, that was done by castration, removing the testicles. But nowadays, we have other approaches to stop the effect of testosterone, either by drugs to stop production of testosterone or using drugs that stop the effect of testosterone on the prostate cells. Sarah, next slide, please. There can be side effects with hormone therapy. Hormone therapy isn't focused just on the prostate, and it can have effects on other tissues around the body. It might affect libido, resulting in low sex drive, erectile dysfunction. There could be changes in the way that you think, so you have difficulties in concentrating, you might feel more fatigued, memory problems. You may see breast swelling and tenderness, weight gain, predominantly fatty gain, loss of strength and muscle mass. You might experience loss of body hair, and quite bothersomely, you may experience hot flushes. Many of the side effects can be treated, so if you were to experience those, there are approaches we can take to help. Sarah, next slide, please. Broadly speaking, hormones have a major role in advanced prostate cancer. But we also use hormones in localized high-risk prostate cancer if you're having radiotherapy. If you've got high-risk localized prostate cancer, you've got two main treatment options: surgery to remove the prostate or radical radiotherapy. And studies have shown that if you use radiotherapy in combination with hormones, either given before, during, or after the radiation treatment, it can make the hormone, the radiation treatment more successful. The duration of treatment varies. It may be 6 months before radiotherapy, and it may be up to 3 years after radiotherapy. Sarah, next slide, please. So the advantages: it can be used alongside other treatments to make them more effective. So it's a synergistic role. It's an effective way to control metastatic prostate cancer, that is, cancer that's spread through your body. And it can help reduce some of the symptoms related to advanced prostate cancer, if it's metastatic or pressing on tissue locally, causing symptoms such as pain, discomfort, etc. The disadvantages are there can be considerable side effects, and that will impact on the quality of your daily life. If you've got metastatic disease, the role of hormones may put the brakes on the growth, sometimes for many years, including decades, but it won't cure your prostate cancer. It just puts the brakes on. Sarah, next slide, please. Okay, so a summary of what we've been talking about. Localized prostate cancer is cancer that's confined to the prostate gland, has a low risk of spreading. We do categorize those that are at high risk and low risk. And high risk, we'll think about aggressive management with radiotherapy, with surgery. But for many people that have lower or medium risks of cancer, we can offer monitoring. We can hold off treatments until they're necessary, or unless a patient has a strong desire for active treatment. There are opportunities for those with medium risk prostate cancer to have focal therapies. This is essentially a new, some consider still experimental approach to treatment, but the gains here are that it can control the localized prostate cancer, but avoid some of the major side effects seen with the conventional approaches of radiotherapy and surgery. Hormone treatments may be used to treat high-risk localized prostate cancer in conjunction with radiotherapy. Conventionally, we see hormone therapy being used in men that have advanced disease, and there'll be additional seminars on that in the coming weeks. The way the hormone therapy works is it blocks the action of testosterone, either stopping its production or blocking its action at the prostate cancer cells. If you've got localized disease, on the whole, those men have a good outlook, and there's many treatments in terms of managing them, avoiding side effects if possible. Okay, Sarah, thank you.